Hi, everyone. Welcome and thank you for attending Get to Know Vibrant's NutriPro and Micronutrient Test. My name is Dr. Lily Lu Wing, and I am a clinical lab educator here at Vibrant America and will be your moderator for this evening. I will be responding to the live chat and Q&A throughout the presentation. Following the presentation, there will be approximately 15 minutes for live Q&A. As a reminder, all attendees are in listen-only mode for now. So please submit your questions through the virtual Q&A or chat application. The content of this webinar is for educational and informational purposes only. The information is not to be intended to treat, cure, or prevent any condition or disease. If you desire medical advice, diagnosis, or treatment, please consult with a medical professional or a healthcare provider. And now let me introduce you to today's presenters, Dr. Kim Bruno and Mary Beth Augustine, who are our clinical lab educators here at Vibrant America. Mary Beth Augustine is a registered dietitian nutritionist and fellow of the Academy of Nutrition and Dietetics. Mary Beth holds a bachelor's degree in food and nutrition and a master's degree in psychology. Mary Beth's past work experience includes 2 decades practicing in integrative and functional medicine departments in 3 teaching hospitals in the New York City area and cardiovascular research at the American Health Foundation. Mary Beth's speaking highlights include the United Nations Committee on Aging, American Institute for Cancer Research, Cancer Survivor Conference, Integrative Healthcare Symposium, Food and Nutrition Conference and Expo, and the Hawaii, Massachusetts, Nebraska, New Hampshire, New York, West Virginia, and Wisconsin Academy of Nutrition and Dietetics meeting. Mary Beth has been featured on CBS, ABC, NBC, and Fox 5 News. Today in New York, CNN, Market Watch, Discovery Health TV, and National Public Radio. A longtime Hodgkin's disease cancer survivor, brain tumor survivor, and hearing impaired disability advocate, Mary Beth is dedicated to sharing her personal and professional passions to educate people about integrative and functional nutrition, disability studies and diversity, equality, and inclusion in healthcare settings. Dr. Bruno received her doctorate in chiropractic medicine from National University of Health Sciences in Chicago and successfully completed the Certified Clinical Nutritionist Board examination. She has continued her postgraduate education through the Institute for Functional Medicine, the Clinical Nutrition Certification Board, and Lyme's master courses. Dr. Bruno has dedicated her career to working to find the root cause to patients' medical issues, as well as promoting a prevention model of healthcare. Prior to coming to Vibrant America, she owned a private practice and worked hand in hand with a variety of healthcare practitioners in multidisciplinary practices. Most recently, she was the functional medicine director at the largest immunology clinic in Colorado and specialized in complex care of patients with multiple chronic immune conditions, developing immune rehabilitation plans for optimal health. Dr. Bruno is a Colorado native who enjoys hiking, skiing, and paddleboarding and finds most joy in spending time outside in nature with her husband and 2 young daughters. So now I'll turn it over to Dr. Bruno and Mary Beth.
Thank you for that warm welcome, Lily. I'm excited to present the micronutrient test to you this evening. Dr. Kim Bruno will present on the NutriPro test shortly. So without further ado, let's get started. So the Vibrant micronutrient test has a number of advantages, but the first thing I would start with would be essentially that it is a direct quantitative test. It is a direct quantitative measurement of micronutrients circulating in serum and micronutrients that have been transported across the white and red blood cell membranes. That can be compared to competitor labs that use more indirect testing methods, such as lymphocyte proliferation in cell culture medium. As with any type of laboratory test methodology, there are strengths, limitations, and scientific uncertainties associated with both direct and indirect methods. The Vibrant micronutrient test is performed with the use of liquid chromatography, mass spectrometry, and inductively coupled mass spectrometry. This state-of-the-art technology allows the highest sensitivity of detection. And patient samples are essentially taken, whether they are blood, urine, or stool. In this test, for the micronutrient test, they're blood, but patient samples are separated using chromatography. The chromatograph technique used really depends upon the type of analyze that you're looking to detect, whether it's liquids or solids. So gas chromatography is used for detecting acids like organic acids and fatty acids. Inductively coupled mass spectrometry is used for detecting metals like heavy metals in our heavy metals test. And liquid chromatography is used for other liquid molecules. An example are micronutrients. Once the components are separated by the chromatography, essentially the sample is injected into the mass spec instrument where it basically smashes, sorts, and detects. And in the smashing phase, the molecules are turned into gases, and that sorts the fragments, and then you can identify the fragments based on their molecular weights. The sample is injected into the mass spectrometer through a little inlet, and then the sample is vaporized by heating it under a vacuum, and next it's pushed into the smasher, where it ionizes the molecules by removing one or more electrons to form ions. And then the charged and uncharged particles are more easily sent to the weighter where they're sorted, and you can detect the molecules according to their molecular size and weight. The smallest molecules are detected first, the largest are detected last. What's pretty cool about this whole process is that you can basically test any matrix, you can evaluate for any type of interference, and you can identify almost any particle size, literally down to the limit of detection at the parts per quadrillion level. So think about it, if you had a pie and you cut it into 1 quadrillion pieces, you'd be able to detect that one little quadrillion. So very, very, very high sensitivity test methodology. There are definitely limitations to, as I mentioned earlier, strengths and limitations and scientific uncertainties to different methods. Some competitors do use micronutrient testing in cell culture, and there are some disadvantages to that. Essentially, cell culture really tries to mimic the in vivo environment, and cell culture growth medium, like little kind of micronutrient baths in the cell cell culture plate, really the concentration of micronutrients that they put into the cell culture may not accurately reflect physiological levels. And essentially, cell viability research is still needed with this method, and genomic stability research is still needed. At Vibrant, what we do, we really get a direct quantitative measurement of the micronutrients inside the cell. How that's done is Vibrant essentially measures the intracellular nutrients after lysing the cell membrane. So basically just bursting the cell membrane open and then measuring the release lysate, in this instance, the release nutrients. And the results are expressed as a ratio of the total white blood cell count. A low white blood cell count may concentrate this micronutrient soup, if you will, and that can kind of skew the results. So, an example, if you had 2 parts of vitamin A in a ratio to 10 white blood cells, the results would reflect about a 20%. Versus if you had a high white blood cell count, it's going to dilute the soup. It's going to skew lower. So in that example, if you had 2 parts of vitamin A to 100 white blood cells, now the result would be 2%. So for those among you who are maybe math phobes, I'm going to raise my hand here. I find it's easier just to remember that it's an inverse relationship. I don't focus so much on the concentration or the dilution, but I remember that for a high white blood cell count, it's going to skew lower, and for a low white blood cell count, it's going to skew higher. I want to be adamantly clear that this does not invalidate the results. Like any test, the strengths and limitations really you just need to apply critical thinking to compare the white blood cell results to the serum and red blood cell results. This same method of lysing the cell membrane is what's used to measure our red blood cell micronutrients as well. You basically lyse the membrane, release the nutrients measured. However, there's much less temporal variability in red blood cells. They don't change as quickly as white blood cell counts can change, right? If we learned anything from the COVID pandemic, we see, infection, you can see, immediate rise in your white blood cell count, along with other types of infections, not just, viral or COVID. But you really can have high day-to-day variability in the white blood cell counts, which you don't have that same level of high variability for red blood cells. So you won't see any skewing of the red blood cell micronutrient results. Anecdotally, what we see here at Vibrant, I've probably reviewed about 3,000 micronutrient tests in my 4.5 years here at Vibrant. And invariably, more often than not, you really see a trend for agreement between serum white blood cell and red blood cell levels. Not for every micronutrient, you'll definitely see some disagreement, and we're going to discuss that a little bit here. But by and large, we see commonalities across the blood compartments. I think there's a great advantage of testing serum and red blood cell micronutrients. And I know, having practiced in, first complementary alternative medicine and then integrative medicine and then functional medicine centers, there has been criticism of measuring serum and red blood cell micronutrients. But I would really like to remind everyone present today that there are extensive studies on testing serum and red blood cell micronutrients. In particular, it's validated in healthy populations, different biological sexes, different ages and stages of the life cycle. We're talking at least 70, 80 years of testing serum and red blood cell micronutrients. Also been validated in many ethnic and racial populations, though research disparities still do exist, unfortunately. Serum and red blood cell micronutrients have been validated in every disease state that we've ever read any study about, whether it's ulcerative colitis, Crohn's disease, kidney disease, neurodegenerative diseases, cancer, etc. Really, the bulk of the scientific literature is on measurements of micronutrients in serum, plasma, whole blood, red blood cell micronutrients. So you really have advantages of having the serum and red blood cell micronutrient testing along with the white blood cell testing. I also want to highlight that all of our wonderful functional genetic polymorphism studies that have been ongoing in the past few decades, they too have used either serum or red blood cell micronutrients, definitely some leukocyte micronutrient measurements there too, but by and large, most of the studies have been done in serum, whole blood, plasma, etc. So I think there's a tremendous advantage of having serum and red blood cell micronutrients along with your white blood cell micronutrient measurements. And last but not least, having serum and red blood cell micronutrient levels is an advantage when you're comparing them in people with low or high white blood cell counts. And if you think about, the incidence of infection, again, autoimmunity, you can really see a lot of temporal variability. And last but not least, competitors who measure micronutrients in lymphocytes only are at a disadvantage because only about 20 to 40% of white blood cell, 20 to 40% of all of the total white blood cells are lymphocytes, whereas Vibrant measures micronutrients in all white blood cells, not just lymphocytes. Regarding extracellular and intracellular, basically extracellular micronutrients are those that circulate in blood and exist outside the cells. Again, this is a temporal measure of what's in the blood at any given time. It's like a snapshot, right? It reflects a micronutrient status over a short time frame. Whereas intracellular micronutrients are micronutrients that have been transported across cell membranes of either the white blood cells and the red blood cells. they do reflect the nutritional status for the lifespan of the cell, which is much longer than the circulation time in blood. Cellular transport and uptake of micronutrients is important in maintaining and promoting optimal functioning of all our cells, and we are nothing if not a bunch of cells. People consuming, it's definitely important to remember when interpreting your intracellular results. One of the common refrains we hear is, but my client eats a really clean diet, and they take, high quality pharmaceutical grade supplements. That may very well be the case, but they may still have insufficient cellular levels of nutrients for a multitude of reasons, including but not limited to a loss of nutrients via the GI tract or the urinary tract or skin, impaired transport and uptake of nutrients across the cell membrane due to cell membrane oxidation or inflammation, and what Dr. Bruno is going to dive into deep tonight, genetic variants which can impact micronutrient metabolism. We cannot talk about micronutrient status without talking about nutrient absorption in the GI tract. We must consider gut function, leaky gut, dysbiosis, pathogens, gut inflammation, or malabsorption. I would highly encourage practitioners to order a gut Zoomer in conjunction with their micronutrient test. Beyond the scope of this lecture, really to give an overview of nutrient absorption in the GI tract, but I will highlight a few things, just a brief refresher. Essentially, the stomach absorbs iodine, fluoride, and molybdenum. So if a patient has GERD or gastritis or hypochlorhydria, among other upper GI conditions, absorption of these nutrients may be impaired. As we know, the majority of nutrients or most nutrients are absorbed in the small intestine, in the duodenum and the jejunum, some in the ileum too. But just thinking about the small intestine, how many practitioners, present this evening are working with patients with SIBO? People with SIBO simply cannot have optimal micronutrient status. Just like in real estate, it's all about location, location, location. So absolutely, ordering micronutrients in conjunction with your gut microbiome testing is really critical. Before food and waste makes its final journey into the large intestines, bile salts, bile acids, B12, and vitamin K, among other nutrients, are absorbed in the ileum. I would encourage you to be, clinically suspicious of patients that have right lower quadrant pain and cramping and diarrhea after meals. They're more likely to be malabsorbing those micronutrients that are absorbed in the ileum, like vitamin C and folate and B12 and vitamin D and vitamin K and magnesium. And then last but not least, on its final journey through the GI tract, you've got absorption in the large intestine, where you absorb sodium, potassium, chloride, vitamin K, which is why you can see in so many motility disorders issues with like hypotension, electrolyte abnormalities. And you also have both absorption of dietary vitamin K as well as synthesis of vitamin K by gut microbes. You also have biotin and short chain fatty acid absorption in the large intestine. So people with lower GI disorders, motility disorders, as I mentioned earlier, pelvic floor dysfunction, they're at a higher risk for deficiencies and insufficiencies of these nutrients. When you open the results for your micronutrient test to begin interpretation, it is critical to look at the date of service. Really understanding the date of service and what happened in the week, the month, and the 3 to 4 months before that date of service is really critical. Essentially, otherwise you're just kind of guessing at a cause and effect. Essentially, serum micronutrients reflect a few hours to a few days, approximately a week, we'll say, before the date of service. Every micronutrient has variability in how long it circulates in serum, but it's absolutely a short circulation time. It reflects a short-term micronutrient status. Again, in general, about a week. For white blood cell, you're really looking at the lifespan of the white blood cell, which among the white blood cell lines is variable, but essentially it reflects roughly 3 to 4 weeks before the date of service. And then red blood cell, if you remember from, your hemoglobin A1C, why you test it every 3 to 4 months, it's because the lifespan of the red blood cell is about 3 to 4 months, 90 to 120 days. And I again want to emphasize that this is the lifespan of white blood cells and red blood cells under normal physiological conditions. The white blood cells can vary rapidly, the red blood cells less so, but you would always have to consider people, with any type of hematological disorders, or chronic, lymphocyte disorders, proliferative disorders, et cetera. Take that into consideration when in your interpretation. And we get those questions all the time at Vibrant, and we are happy to guide you through that. So what do you really need to know about the lifestyle and data service? I say that this is a test that is best interpreted with your client or patient present. During consults, these are the type of questions we'll ask you to consider. But again, if you're just looking at the results on paper without the clinical history and knowledge of the lifestyle in the week, the month, and the 3 months before the data service, it kind of puts you at a disadvantage when you're trying to figure out, what may be the root cause of some of the abnormalities and how to proceed with an intervention. So you want to make sure that you ask your client or patient, did they, in the week, month, or 3 months before the data service, did they change their diet? Did they change their fitness regimen? Did they perhaps initiate, discontinue, or change a dose of medications, or initiate, discontinue, or change a dose of supplements? Did they experience any type of a life event, a change in stress or a trauma? Did they have an acute infection, illness, injury, or surgery? Or did they experience a worsening of their chronic illness, infection, or injury? Knowing this information will really allow you to interpret the abnormalities in the serum, white blood cell, and red blood cell micronutrients. So let's do a little report walkthrough. So these are what we call, on the left, the micronutrient dial charts. And they're fairly intuitive to interpret in that the micronutrients are grouped by body system or structure and function. However, it's important to know that the dial chart scores really assign a different weightage to each micronutrient based on its importance to the specific body system or to the structure or function. So an example, for the neurological and cognitive function and mood score, a higher weightage is assigned to EPA and DHA, and a lower weightage is assigned to CoQ10 and vitamin E. Whereas in the cardiovascular health score, you would have a higher weightage assigned to CoQ10. So I think that's not intuitive, certainly not for your clients or patients. And sometimes they'll question why the scores, which they might think should be higher or lower. So really educating them about the different weightage assigned to each nutrient based on its clinical significance to that body system or structure and function is important. The goal is to be in the green, and that is a score above 86. It's just like your test, right? The closer you're getting to 100, the better it is. There are definitely some common misperceptions that require education of clients and patients. One of the common misperceptions is that a high score equals health and a low score equals disease. And rather, you should educate that the scores are associated with risk associated with those high or low results. So you could have a client or a patient with SIBO who has a 92 score for GI barrier, or a client or patient with hypertension, hyperlipidemia, arrhythmias, and they've got a cardiac health score of 88. And they kind of, think, oh, this is a conflict, this is discrepant or discordant, these scores can't be right. In that scenario, you assure the client or the patient that while they have these conditions or disease states, their micronutrient status is currently desirable and it's not contributing to their risk at that current time. Maybe last year it was, maybe next year it'll be, but on the other hand, if those same scores were less than 86, there's definitely work to do. So to begin assessment, ask yourself, do these scores correlate with your clinical suspicion? and prioritize the scores, starting with the lowest scores and the scores that are associated with the known clinical history first. And sometimes we open up a micronutrient report and there's like 30 abnormalities, and you're like, whew, where do we start first? And again, so if you prioritize based on the lowest scores in the dial chart and those scores associated with the known clinical history, it can really kind of guide your decision making. The next page is the abnormalities at a glance. I spend about 90 seconds on this page, but I do find it really sets me up for success. It really informs my thinking for the rest of the test. And what you want to do, or you want to observe for 3 types of patterns. And the first pattern is a pattern of abnormality by blood compartment. So do you see more serum or more intracellular abnormalities? That would give you insight into how recent or how long-term the micronutrients have been abnormal and impaired. And it can inform your inquiry with the client or patient by asking, again, what was going on in the week before the test, or the month before the test, or the 3 months before the test. We had a pretty cool scenario. We've had multiple cool scenarios, but one of them was a avid outdoor enthusiast, hiker, mountain climber, grew up on a farm, used to swimming in every type of body of water. She swam in a lake. She was camping, swam in a lake that had a little bit of a microalgae scum on it. Didn't think anything of it, real nature enthusiast, had swam in a bunch of lakes like that all of her life. And yet, the less than 24 hours later, she came down with incredibly high fevers, vomiting, diarrhea, couldn't hold down a bite of food, lost 15 pounds over 2 weeks. And then as she started to recover, was able to eat, gained 5 pounds. And when we had looked at her results, which were almost 2 or 3 months later between the time she got tested, we asked her, I said, what was going on? Can you look back in your phone and your calendar and tell me what was going on around August such and such? Because essentially her serum micronutrients looked pretty good, but her white blood cell micronutrients were in the tank, like worst case scenario. And sure enough, she looked back and she's like, oh my gosh, that's right. I went camping, I threw up, So, I've heard so many scenarios like this. We had a tax accountant. It was April. He did the testing at the end of April. His serum levels were looking better than his intracellular levels. I asked the question, look back at your calendar. Can you tell me what was going on early April? His red blood cell levels were low too. And turns out, he said he makes his entire income in the 3 months before April 15th. And usually, he says, I don't eat, I don't drink, I don't sleep, I don't breathe, I don't use the bathroom. Sometimes you can really tell the story just on paper. You can see the story or the narrative emerging. Another pattern you can look for is the directionality of the abnormal results. Are there more highs or lows? This pattern can inform your thinking about the causes of micronutrient overloads for highs. Maybe they just have a repetitive or low diversity diet. Maybe they have genetic variants that predispose towards high levels of nutrients, or maybe they're just taking too much supplementation. Or if you see a pattern of lows, you can assess for causes of micronutrient deficiency, such as poor intake, nutrient losses via GI tract, urinary tract, or skin, increased utilization, or genetic variants that predispose towards insufficiency or deficiency. And then the third pattern you want to look for is a category of abnormal micronutrients, like the B vitamins or the fat soluble vitamins or minerals or antioxidants, amino acids or fatty acids. Again, I've opened up this page and seen cysteine, glutathione, vitamin E, selenium, zinc low. And I'm like, whoa, what's going on with this person's, stress level, their oxidative stress, inflammation, or are they an athlete and, they've got increased utilization of the antioxidants? Are they a smoker? So again, just spending about 90 seconds looking for the patterns on this page can really inform your thinking for the rest of the test results. So how do we interpret, results, normal versus optimal, essentially? The micronutrient reference ranges use the mean as the calculated average of all values for the healthy reference population. And the area in the green, over here on the little bar chart, you see the area of the green outside of the, and the, in between the red, reflects 95.5% of all reference value population sampled. So this is where you want to be in that 95.5%. The faint gray lines that you can see above and below the mean reflect either 1 or 2 standard deviations above or below the mean. When you interpret normal results, you really want to assess whether the levels are either borderline or subclinically low. You want to assess if they're insufficient, desirable, optimal, or borderline high. As with most laboratory tests, when you've got a two-sided cutoff, right, a low and a high, we generally want to see the results hovering around the mean, indicated by that little red arrow on the slide. And always a good argument can be made for the benefits of having slightly to moderately above average levels of certain micronutrients. So something like higher, more robust levels of chromium in insulin resistance or PCOS, or higher robust levels of niacin in hyperlipidemia, or B12 and methylmalonic acidemia, or K2, vitamin D and magnesium and osteoporosis. You can always argue that maybe you want to see stronger than the average, maybe in that 60, 70, 80th, 85th percentile. In those clinical scenarios, optimal really depends upon the clinical history. However, for micronutrients that really start to reach, the 1 to 2 standard deviations above the mean, then you want to, think about the potential risks of micronutrient overload or toxicity. And, do you want to cut back on your supplementation? So if we think about micronutrients, there's a U-shaped curve, right? In a U-shaped curve, there are risks at both ends of the curve. So for low, it's a deficiency. For borderline low, it's an insufficiency. Borderline high, you start to get overload risk, and high can give potential toxicity. Clearly, we know that insufficiency and deficiency are undesirable. We don't have to debate that. And when you begin to correct it by supplementation, you really want to have ongoing monitoring and evaluation to prevent the risks and harms of micronutrient overload and toxicity. And this is where you want to retest, essentially. For certain nutrients, the risk of toxicity is quite low. Think about pantothenic acid, like no harm of high levels. For other nutrients, the risk of toxicity is much higher, such as vitamin A toxicity, iron overload, B6 and neurotoxicity, or the narrow therapeutic window of some of the metals, such as chromium, copper, manganese, and zinc, just to name a few. So really looking at those more critically as they start to approach upper levels. For other micronutrients, high levels in the absence of supplementation may indicate pathology, or, as Dr. Bruno will discuss, genetic variants that increase nutrient absorption, transport, or uptake. So the bottom line is, when supplementing, you want to test, don't guess, of course. And then for ongoing monitoring and evaluation, you want to retest, don't guess. So essentially, here's just an example of the B6 U-shaped curve. This 2020 article by Lanska really nicely highlights the B6 U-shaped curve and its impacts on multiple body systems, including hematological, dermatological, cardiovascular, gastrointestinal, and neurological harms. The bottom line is we're looking for that sweet spot of micronutrient status, not too high, not too low, okay? B12 U-shaped curve is another common phenomenon, especially that we see here in patients being tested. I think we have a little selection bias compared to the rest of the healthy population. Many of the patients we see are, supplementing with B-complex supplements and, focusing on methylation, methylated supplements, etc. So we do tend to see a lot of high B12 levels. So as a clinical lab educator here at Vibrant, observationally, I have witnessed hundreds and hundreds of times when B12 levels are elevated, sometimes even beyond our limit of detection. that upper cutoff where we can't even detect it. It's gone so high, we can't detect above it. Many practitioners consider hypercobalanemia non-significant, benign. However, I would argue against that, as this review article on the pathophysiology of elevated B12 in clinical practice clearly opines that hypercobalanemia is a frequent and underestimated anomaly. It can indicate a functional and qualitative B12 deficiency, and a functional cobalamin deficiency can occur at any B12 serum level, low or high. You always want to evaluate other markers with B12, and so MMA and homocysteine are definitely key biomarkers in the evaluation of functional deficits in B12. And practitioners should rule out kidney and liver disease, hematological abnormalities, neoplasms, and hematological malignancies, as well as B12 and MMA genetic variants altering B12 status. So I really feel strongly that high B12 is, needs to be managed very, critically. Examine the root causes and make sure there's, no harms from it. So when we look at the genetic basis of the B12 status, this was an interesting article that examined, it was a 2018 article by Surendran et al. It evaluated 16 international studies, and they identified 59 different B12 polymorphisms that can result either in lower or higher B12 status. Like much of the research, there's definitely overrepresentation by Caucasian populations, so more research is needed in diverse racial and ethnic populations. I want to highlight that Vibrant tests 7 B12 and MMA gene SNPs that significantly alter B12 status. And stay tuned for Dr. Bruno to drop some more nutrigenetics and NutriPro wisdom on you. But now let's go back to interpreting the micronutrient test for agreement and disagreement. So agreement is when you have basically the serum and the white blood cell levels in agreement. And that's easy. Everybody knows what to do then. Like, oh, wow, if it's too low, I need to supplement. If it's too high, maybe I need to adjust the dose of the supplementation, or maybe I need to look for repetitive dietary sources of the micronutrient. In the slide example here, you'll see that for K2, the serum and white blood cell are in agreement. For manganese, however, you see disagreement with serum greater than the white blood cell. And for glutamine, there's also disagreement in this scenario with the white blood cell level greater than the serum level. Most practitioners base their supplementation decision-making on the intracellular levels, of course, because it's the longer-term micronutrient status. It makes perfect sense, right? However, the one caveat would be that when the corresponding serum nutrient is high, while the white blood cell or red blood cell nutrient is low, and if that nutrient has a potential risk for toxicity, like the aforementioned B6 or the metals like chromium, vanadium, chromium, zinc, molybdenum, etc., iron, in those scenarios, you may want to get a repeat measurement that may be helpful or beneficial to determine the dose of supplementation, the frequency of use, and the duration of supplementation. Because we need to remember that these results are temporal. They represent a moment in time, like a screen capture. Let me share a great study on temporal variability of micronutrients. This was one of those light bulb moments for me in practice. This study examined 381 subjects, and they took serial measurements of 25 micronutrients every 4 months. And 2 to 3 measurements, they were trying to find that sweet spot of how many measurements were needed to be predictive of a person's true value or that person's norm. Like, what is the norm for Jane Doe or John Smith? They found that 2 to 3 measurements of micronutrients were needed to be 80% predictive of a person's true value or norm. And 4 or more measurements were required to achieve greater than 90% of a person's true value or norm. This made sense to me when I thought of macronutrients, right? Like if I'm tracking my protein, carbs, and fat, Monday maybe I eat 60 grams of protein, Tuesday maybe I eat 96, Wednesday I eat 112, Thursday I eat 57. So the more measurements you have, the more likely it is to predict the person's norm. In that scenario, none of those, you'd have to kind of average it. Now, if Monday I had 65 grams of protein, Tuesday I had 71, Wednesday I had 61, Thursday I had 68, we go, wow, that's really highly predictive of the norm. They're all in a very clustered range, right? Interestingly, this study found that persons at higher nutrient levels had more within-person variability. This has been seen in previous studies as well, including with vitamin D, where higher levels result in a steeper and more rapid fall when supplementation is rapidly discontinued. This relationship also held true for a study of antioxidants and oxidative stress biomarkers, in which 3 to 4 measurements were required for greater than 90% of the person's true value. Again, the take-home point here is retest, don't guess. Decision-making considerations. Essentially, what you want to take into account is what is the intake of micronutrient from all sources, from diet and supplements. Are there losses of micronutrients from the GI tract, urinary tract, or skin? Is there increased utilization of micronutrients? We had a guy, he did his test on like a Wednesday. His serum levels were in the tank. His white blood cell levels looked fabulous. His red blood cell looked fabulous, like poster child. And I was like, what was going on, in the few days to the week before the data service, because something clearly changed. Turns out he ran a marathon on the weekend. Oh, well, that would explain why all of his amino acids were low, all of his antioxidants were low, all of his B vitamins were low, his magnesium, role in muscular contractility were low. So really, again, getting that clinical history is really critical. You want to assess, are there drug-induced nutrient depletions? Could cellular transport and uptake be impaired due to lipid peroxidation, oxidative stress, inflammations, or heavy metals, and environmental toxins impacting membrane permeability? These might be, further tests that you want to work up, for root causes of abnormalities. And last but not least, focus of tonight's, topic, could there be genetic polymorphisms impacting abnormal intracellular results? We're wrapping up in a few slides, and then we're going to go to Dr. Bruno, cell aging, longevity, and inflammaging. Micronutrients play a critical role in cell aging, genomic stability, and telomere length. Deficiencies can mimic radiation and chemical toxicity. They can cause DNA strands and breaks. They can serve, micronutrients serve as cofactors in cellular processes. They play a role in inflammaging and biological age. So basically, you are what your DNA eats. While we've discussed the strengths, limitations, and lack of scientific agreement and some of the scientific uncertainties around understanding micronutrient status, that doesn't mean we should do nothing until further research informs us of best practices. Rather, this is a call to action. Imperfect action is better than perfect inaction. And that with ongoing biomonitoring and surveillance, if you test, don't guess, and you retest, don't guess, you can have great outcomes for your practice and patients. I'm going to turn it over to Dr. Bruno now.
Thank you very much, Mary Beth. I'm going to get my slides up here. Okay. Just want to confirm that everybody can see my slide here.
Yes.
Very good. Thanks, Lily. Okay, so thank you so much. Now what we're going to do is we are going to talk about how we can optimize our micronutrients through the use of genetics to really help to create a very precision approach for our patients. So today I have can get my slides to go. There we go. So today we have our learning objectives. I'm going to talk about genetics in healthcare, the difference between nutrigenetics and nutrigenomics, a little bit of a genetics refresher, just so that we are all on the same page. We're going to talk about the Vibrant Advantage as far as what we offer through our testing. And then we're going to do the fun part, right? We're going to apply this all clinically, because if you've seen these NutriPro reports, it's a lot of information. And so I'm going to walk you through how we can really, maybe a sample report. We're going to talk about how to develop a clinical plan for your patient. So there's various types of genetics in healthcare. So you can have some of the traditional, like commercial or medical testing, which have been around for a long time. These are going to be things that are more disease-based. We're going to be looking for traits or carrier status. A newer form is more of these ancestral origins. Those are examples of like 23andMe and Ancestry. And that is really one side of the coin. There's also pharmacogenetics there. There's also what we would call nutrigenomics, nutrigenetics, and this has to do with metabolic weaknesses, or where's the breakdown in the biochemistry. So it's not disease-based. We're not trying to look to see if somebody has a disease based on these SNPs, but we're looking at maybe some dysfunction or problems, hiccups, if you will, in the biochemical pathways. And how can we develop actionable items or actionable steps as the provider to be able to optimize their health in the long run? So when you can do that with the use of the genetics in that second column that I talked about, we can create this really personalized, proactive, preventative healthcare plan, and we can use the genetics to make nutritional decisions. This is really great because I've been doing clinical nutrition for 15 years, but once we were able to apply the genetics to the nutrition decisions, everything really opened up, because we are all similar, but we are not the same. And so now what we can do is we can look at that nutrient metabolism as it's related to the genetics, and we can make better choices for the patient today, but also for the future of anything that they might come in contact with. Additionally, when it comes to compliance, which a lot of us as providers, we really, really are, interested in making sure our patients are compliant with the plans that we have because it benefits them, is that when we share genetics with our patient, they're more likely to stick to the plan. And so therefore they have better compliance, and therefore they have better outcomes. So let's talk about nutrigenetics versus nutrigenomics. So understanding the difference in the differentiation, then it can really help to understand what we're looking at in the realm of clinical nutrition. So nutrigenetics is the study of how genes determine the effect nutrients have on your body. So how your body responds to what you eat is your nutrigenetic profile. So I think about this when I think about patients, of how much of a particular nutrient does my patient need to consume through diet or supplementation based on their genetic variants. And that may change depending on how much they can absorb or transfer throughout their system. So there's a couple examples here. You're going to see a lot of this through the report. And I saw somebody in the chat mention FUT2, and Mary Beth mentioned it too, is that, something like the FUT2 genetic variation can make you more prone to low absorption of B12. This is going to be intracellularly, right? So they can have maybe an elevated serum level, but they could have a decreased intracellular level. Now, nutrigenomics, on the other hand, is pretty much the opposite of that. So where the nutrigenetics is providing information about the genome and really what you should eat, the nutrigenomics is how the food you choose to eat causes your genes to be expressed in a certain way. So when we are looking at that, then the example would be like the famine study, where we had a group of women who were in a famine and they consumed 400 to 800 calories during this famine period. And then their offspring were studied later, and we had elevated rates of obesity and cardiovascular disease and poor health markers, high cholesterol, all based on the nutrigenomics of that type of situation. So it's more about how the genes are expressed. So this is a really great little summary graphic to demonstrate that interplay of genes and nutrients and that differentiation between the nutrigenetics and the nutrigenomics. So again, nutrigenetics, how your genes affect how your body responds to food. Nutrigenomics, how what you eat affects how your genes behave. So we are going to be talking for the rest of tonight's presentation about nutrigenetics, because that's where the NutriPro fits in. It is a nutrigenetic panel. All right, so before we get too far into the weeds on the test panel, I just want to review a little genetics 101 so that we have the right terminology, okay? So in nutrigenetics, we are referring to SNPs or genetic variations, not mutations. Mutations are often going to refer to an insertion, a deletion, a duplication, which are rare and often result in some sort of a disease state. A SNP, on the other hand, which is a single nucleotide polymorphism, is a single germline substitution and of a certain nucleotide, and then that can alter the protein and therefore has the potential of altering some function. Doesn't mean it always does, but has the potential. So in this example here, the let's see here, we have the adenine and the thymine are going to be substituted here with the guanine and the cytosine. And so therefore we will have an altered protein because of that SNP at that particular site. So again, we are dealing with SNPs and variations, not mutations. So this is the, another example of the SNP. And then the RS ID, which is something you will see on the report, is the actual location where this, the SNP substitution takes place. So where that nucleotide substitution takes place. So this may be the gene, and this location right here is going to be the RS number. And certain RS numbers have more affinity to creating, altered protein status than others. And so that's why the RS number is important, because it's not always the gene, but it's really the RS number of where that takes place. It is important to remember that all this is really great information. Looking at these SNPs in isolation it's not really recommended to use these. One, they're not diagnostic as far as created for a disease, and we really shouldn't be using them to only, just the SNPs to prescribe or create our treatment plans. It's really better to use them as part of a complete picture to help put our patients' results into perspective. So following along with that SNP type terminology, so now we know what a SNP is, and you can have a couple different types of SNPs. So you could have a homozygous wild SNP. This is the most commonly found in nature. It is considered the normal type. Now note, I don't say good. There are specific situations where the homozygous wild type, which maybe is the most common, is actually the one that also causes the deficiency. And the patient who has the homozygous variant could be the one that is protected. So it's not necessarily always good, but it does mean that it is the most common within that population. Then we have the heterozygous. This means we're going to have one base change, okay? And then depending on the gene and that RS location that we talked about, there may or may not be a genetic risk to that SNP. And then we have the homozygous variant. Now this means we have two base changes, usually present some sort of genetic risk or alteration. Again, like I mentioned before, in a few cases, it may be something that's actually beneficial to the patient, but it's less common. And remember, this is a homozygous variant, not a homozygous mutant, because our patients don't like to be referred to as mutants. That's my only joke for tonight, so you can laugh. Okay, so this is the terminology in action. So this is what it looks like in the report. So you'll see you've got the SNP ID with the RS number over here. And then you have what the nucleotides are. So what those switching, what it's going to be listed as there. Then you're going to be listed if it's an elevated or normal risk. and the result here. So you can see here that we have a homozygous variant with an elevated risk, represented here in red, whereas down here we have a heterozygous. It's represented in green with a normal here with no known genetic risk. And it continues to go on. So we can also have heterozygous with elevated genetic risks that maybe have a higher, chance of having some sort of deficiency with a double red here versus something that is showing only one red, but still an elevated risk. So we just have a little bit of decoding when we look through the test result, but it all is going to fall into that either homozygous wild type or homozygous variant or the heterozygous. And then depending on that, you'll figure out your risks from a genetic perspective. Okay, so clinical applications. We're getting into the fun part. So as far as the Vibrant testing platform, what we're looking at for the genetics is we are utilizing real-time PCR technology. This is going to offer you an increased sensitivity and specificity to detect the polymorphisms at those particular RS locations. So we have a 99.6% sensitivity, 100% specificity, and 100% reproducibility. When we're talking about genetics, that's really important because you're testing patients to develop a plan that they're really going to be utilizing for their lifetime. So you want to make sure that you have the right information. So you have this very high sensitivity and highly specific test. And then what we're going to do is we're going to pair it with the same micronutrient that Mary Beth just talked about. So the same analytes with the same red blood cell, white blood cell serum levels, all of that done on mass spec, again, with that high sensitivity and specificity, and we're going to bring them together. So we have all had those patients, right, that you've been ordering micronutrients, because I ordered micronutrient tests far before I started ordering genetic tests. And then it was until the NutriPro came on, it was always separate, right? We would order micronutrient and then we'd order genetics tests, and we're trying to fit those things together. Well, now it's all together, but it helps to, when we have them together, the genetics help to put our patients' values into perspective. So let's come back to B12, right? We've had a situation where a patient's serum B12 is high, but they're presenting clinically like they have a B12 deficiency. Well, now we can look and we can say, what's going on with their FUT2? What's happening with some of their other genetic SNPs? Or we have a high serum level and we have a low intracellular level, same within B12. Again, we're going to want to look at those SNPs and seeing what's going on with absorption, how is it being transferred, what's happening in the cell. On the flip side of the coin, looking at genetics by themselves also is not very helpful, because when you look at genetics by themselves, you don't know if that variant is expressing itself in the patient's biochemistry. You don't know if there's some sort of biochemical workaround. You don't know if the patient is currently consuming enough supplements or eating enough of certain foods to kind of override that potential risk that has to do with that genetic SNP. So now bringing those together is really going to give us some clinical success. This is a complete look at the marker list. And as you can see, we've got all the nutrients, vitamins, minerals, amino acids, and fatty acids. And then it does list this, the RSID and the mutated gene here. Now, when we are looking at this, you can find this in the provider portal if you wanted to look through and see, which genes are we testing and how is it related to specific nutrients. But it is a complete micronutrient test. So if you're used to ordering the micronutrient test, this is a really, really great test add-on to do initially, so you get the genetics as well. So best use in clinical practice, it really is to establish the baseline of the genetics. Determine, is there any genetic risk, any predisposition for this patient to any certain types of conditions? And therefore, then we can create this personalized plan for more effective treatment for the long haul. And we're going to go through how we're going to do that. And then after that, you would continue to monitor the associated micronutrients, just knowing that you have their genetics to be able to always connect back and say, oh, that's right, we've got this one genetic SNP, and that's probably why it's affecting this micronutrient this way. So this is an easy an easy panel or slide, because really anybody should get this test, right? Everyone should get it at least once in their life. It helps you to really be proactive, and it can really reach the gamut of types of practices. So whether you're a practice like mine that had really chronic immune system patients, or you have somebody who's a practice that maybe they're just trying to optimize their health or anti-aging, you have elderly patients who are taking lots of pharmaceuticals, you have patients with stressful lifestyles or exposed to a lot of toxicity, which, as we all will see, is all of us. So this can really fit very well as a foundational test into a lot of different practices. So in the next few slides, I'm going to highlight just some of the different sections of the NutriPro as far as what types of sections you'll look. It's a very lengthy report, and so it's helpful to know what we're going to be looking at. So first, you're going to see some summary pages. This is really best to use, just like we would any other summary page with any of our other tests, is as a quick reference, quick at a glance. I like to look at the rest of the results first because it helps me to draw all the connections together, and then maybe come back to the summary page when I'm presenting it to the patient, just because otherwise they might be overwhelmed with all the different pages that are there. In the body of the report, you're going to have two main parts. You're going to get the full results, just like we saw on the summary page right here, right? Where we have the RSID, we've got the gene, we have the result, we have the elevated risk, and then you also have your nutrient list here. Then you are also going to have some really detailed nutrient information. Having information about the nutrients and their function helps you to build the plan that I'm going to talk about here in a couple minutes. And it's nice that it's all in the same report, all in one place. You don't have to go looking for it in a lot of different places. And then you are also in that same page is going to get the detailed genetic information. So guess what? You don't have to be a genetics expert in order to use this test to benefit your patients. The report is going to give you this detailed genetic information for each SNP. Anything that's got an elevated risk, it will populate on there, and then it will tell you what is the altered biochemistry based on the SNP that they have. So great. Again, I don't need to be going over to Snipopedia and trying to pull this all together for this patient. It is all right there in the report. Okay, so that was the big main sections of the report. So how do we utilize all of that information and develop a clinical plan? So you saw that there's just an abundant amount of information. When I was doing clinical calls, patient or providers were always asking me, okay, how do I develop this plan for my patient? I love this information, but it's a lot of data. And so I'm going to call it the 3-bucket plan. Those who've consulted with me know that I like to just name my little plans or name my little, how I'm going to explain things. So this is going to be our 3-bucket plan. And in the examples, I think it's really important for you to know that the information that is on each slide is the same information that's in those lab comments that I just showed you. I purposefully did that. I didn't go out into my nutrigenetic books and pull in some fancy information. I want you to see that the information that is given to you is really applicable. It's very user-friendly so that you can be able to pull this together. So in our 3-bucket plan, when you're looking through your test report, you are going to scan through, and I do this on my on the summary pages. I scan through, and in the first bucket, I put anything that has a SNP without a nutrient deficiency. It's just the SNP. Now, we are going to talk about what do we do with this? Well, there's a couple different things that we can do, and I'm going to give you some examples. So without the nutrient deficiency, this patient is doing okay with whatever they're taking in. So we may just reinforce some dietary and lifestyle guidance for them. We may talk to them about what I call what if supplementation, and you'll see some examples of that, but it's like, okay, this nutrient has to do with X, Y, or Z. if those things happen in your life, we might need to increase some supplementation. Some people will consider a wellness dose if those nutrients are at a borderline situation or they have some contributing lifestyle factors. And you could also give, in some certain situations, you could give some cofactors which could help with the conversion. The nutrients that are in this bucket, we're looking at monitoring about every 6 months for that patient, unless something kind of catastrophic happens. They, were living in a moldy house, they got COVID, they, whatever, something happened. And all of a sudden we're like, whoa, something rocked the boat. Let's retest you sooner. But otherwise, they don't have a nutrient deficiency. We're going to look at just monitoring them every 6 months. Bucket 2 is the actual nutrient deficiencies. Now, they may or may not have a SNP. We do want to look to see, does the deficiency match the genetics? If not, then we need to circle back and maybe look at gut health or food sensitivities or some of those other reasons of micronutrient absorption that Mary Beth mentioned. For the nutrient deficiencies, we are going to supplement at a therapeutic dose. So the ODI, the optimal daily intake, versus that wellness dose, which we were noting at like the RDA. We're also going to talk to our patients about diet and lifestyle guidance around that nutrient deficiency. And then our third bucket, there are only 3 that go into this third bucket. It's either sodium, potassium, or phosphorus. These SNPs have more to do with reabsorption issues. And so then with this, the nutrient level may or may not be out of range, but this has to do more with dietary restrictions than it does supplementations. And I'm going to show you an example of that in just a second, okay? Okay, so I want you to think of these 3 buckets in, as I'm going through this. I have 4 nutrients that I'm going to go through, and I'm going to show you how I would build a clinical case based on this. And now this is a clinical plan that this patient could take with them for a lifetime and be able to monitor their nutrient status and know how to best adjust based on what's going on in their life and how their genetics are playing a role, with that nutrigenetics. Okay. So in order to demonstrate this kind of 3-bucket approach, what we're going to do, how these slides are laid out, is first up here, we're going to identify the function of the nutrient. Okay, so that's that detailed nutrient information you saw in the sample report. So there are going to be many functions, biochemical functions of vitamin C. These are just a couple. Again, I pulled these from the report comments, but when you know the functions of the nutrient, it helps us to determine the situations in which the patient might need more of that nutrient or what symptoms they currently have that might be related to that nutrient. So the first thing on this slide is we're going to be looking at the functions of the nutrient. Then we're going to scan through and we're going to look at the result. We're going to identify that we have a SNP here. And we're also going to identify that we have a low intracellular level of vitamin C and really a suboptimal serum level. We're going to familiarize ourselves with the SNP. And again, based off of the lab comment, we're going to look at this and we're going to say, okay, what does this particular homozygous SNP do? Well, this one is responsible for the absorption and the transport of vitamin C. And this is the homozygous variant here is almost always associated with a deficiency. So, we could know that without knowing the nutrient level, but it's really important now that we have it. So now we can adjust based on that. So if we're going to build our bucket approach here, this part of the report would be in buckets 1 and 2. We have a genetic SNP with an elevated risk, and we have a low intracellular value. So because of that, especially with the bucket 2, we're going to give this patient a therapeutic dose, or the ODI, which is going to be, the ODIs have much bigger ranges than the RDAs. And so we're looking at about 500 to 5,000 milligrams, but that's going to be based on clinical need, provider discretion, right? So it depends on how this patient is presenting. We'll talk to them about food sources, orange, yellow, and red, fruits and vegetables. And then we circle back to the function of that nutrient. And we tell the patient, we educate them and we say, we need to consider increasing supplementation if you get an infection, if you have increased free radical damage, if there's a presence of cardiovascular disease or some sort of musculoskeletal injury. And then we're going to monitor this every 3 months until we reach the optimal levels, micronutrients, that is. Genetics stay the same, so you don't have to monitor that, but you need to monitor the nutrient levels. And then once we've met that level, then we can do every 6 months for maintenance. So let's try another one. So here's glutathione, which is another favorite nutrient of mine, especially when it comes to longevity, detoxification. So we're going to follow the same format. First, we identify what is the function of this nutrient. Then we look at the result, and then we understand what is the SNP association with the elevated risk. So with this patient, they also have a homozygous risk or homozygous variant with an elevated risk here, but their white blood cell level is normal. Now, there may be a provider who wants this level to be more robust, and that's your clinical discretion. You can do that. But at this point, what we can say is this patient is they're either consuming enough through supplementation or through food, or maybe they don't have, an increased need for glutathione. And so even with this elevated risk, they're doing okay. So if we're looking here at our bucket, they're just in bucket 1. They have a SNP present with an elevated risk. The nutrient level is normal. We could talk to them about encouraging dietary sources. If they're supplementing, we can say you can maintain your current supplementation. If we're a provider who feels like maybe this patient has a heavier toxic burden, or they've had a mold exposure, they have immune system need. If they have some additional need to be able to fight free radicals or oxidative stress, we may say, you know what, 223 is not robust enough for me, and I'd like it to be in that upper third. So I'm going to increase your glutathione supplementation to be able to do that. But at some point, if that patient doesn't have any of those things, we could say what you're doing is fine, and we're just going to monitor this every 6 months unless there's some sort of significant change. Right? So they moved into a moldy house. All right, significant change. We know that they have a genetic predisposition to not be able to utilize their glutathione, or they're prone to glutathione deficiency. So therefore, we should maybe recheck them sooner, or do some wellness dosing or what if dosing right there for that nutrient. So when we're looking at selenium, this is an example of where we have 2 heterozygous SNPs. And so they can compound each other, right? So maybe the elevated don't by themselves, one is heterozygous, but when we have 2 heterozygous, that can compound it and get us some more selenium deficiency. All right. So again, we know the function of the nutrient. Now we know the result. We're seeing that serum level is low, but look at this, the white blood cell level is okay. So we do some of the things that Mary Beth talked about as far as like, okay, what was going on the, day to week right before this, did they have some reason why they had some tissue damage or inflammation or problems with, some sort of other cell damage or infection that might have happened. So we could look at that. And then we would put them into the buckets 1 and 2, which are the same ones that we talked about for the first one. So we would give them an ODI based on the clinical discretion of their clinical picture, or the provider discretion of their clinical picture. We'd encourage their dietary sources. We would tell them what to watch out for, and then we would monitor them based on this. So as you can see, you just kind of go through each of these, kind of chugging along and going through, and then the patient has this really, really robust and amazing clinical plan that can last them for a lifetime, right? And if a patient knows like, oh my gosh, I really need to be monitoring, or I should be supplementing selenium and vitamin C when I get an infection because, look at my genetics, that gives them a lot of power. It's great. Okay, so the last one, the bucket 3, remember I told you there's only 3 things that fit into bucket 3, and that is sodium, potassium, and phosphorus. These have more to do with reabsorption. So with this particular gene SNP, the SLC12A3, and you don't have to memorize all of these. Again, they're on the report, but you will start to really be able to recognize them. So this gene is going to regulate that sodium chloride transport and sodium reabsorption from the kidneys. Well, the SNP variation can lead to an increased expression or this increased reabsorption, and that can contribute to hypertension. So we do really want to monitor this patient's sodium intake and their levels, their actual nutrient levels. Now, currently, this patient is doing just fine. They're not even at that upper range. So maybe they already are having a salt conscious diet. But if we're thinking of our bucket approach, what would I tell this patient? Well, I'm going to discuss the sodium conscious plan. I'm going to talk to them about trying to have less than 2,300 milligrams per day, really enforcing that through education. And then we're going to talk about, listen, if you are noticing that you are getting increases in blood pressure, fluid retention, you have extremity swelling, these are things that we are going to need to monitor your sodium level more closely, because you do have a tendency to have more reabsorption at the kidneys that could give you, predispose you to having hypertension. So it gives us that information to be able to also monitor down the line. Okay, so those were my bucket approaches in the 3 buckets. But what happens if it doesn't make sense, right? What if you don't have the genetics that are matching the nutrients? Well, genetics and nutrients are so valuable, but there's lots of other reasons why nutrients might not be absorbed, and genetics is really just a piece of that puzzle. So if you find yourself where the genetics and the nutrients maybe are not making sense, or they don't seem to be matching for certain nutrients, then follow back up with some of the things that Mary Beth talked about, is like looking for those patterns. And then that may lead you into the next level of detective work, right? And that's what we are. We're detectives, and we're looking for some alternate reasons. So we might want to look at their gut health and their digestion, their microbiome. We might want to talk about stress. We might want to talk about, do they have an increased toxic burden that's making them utilize more of these nutrients? Do they have more food sensitivities? So these are things that we can then look at and try and pull together for this patient, so that we can give them that then next step that builds on top of the foundation that we got from their nutrigenetics. Okay, thank you so much for your attention this evening. And I think we do have time for a couple questions. I do also want to reiterate that, the clinical team is here for clinical consultations for you. We're offering these webinars, but when you want to go over your particular results of your patients, we can really help you with the interpretation and the application for your patients, so that you can learn how to pull those things together and develop these plans for your patients. Thank you, everyone.
All right. Thank you, Dr. Bruno and Mary Beth, for the amazingly informative and relevant presentation. So we'll begin the Q&A now. I'm just going to kind of go in the order that it came in. So the first question that we had that went unanswered from Elisa Dinzes. So does that mean we can only recommend supplementation for deficiencies for nutrients with low risk for toxicity? If this is the case, what would be the point in testing those micronutrients with greater risk of toxicity if the patient is only willing to do one test?
I'm happy to answer that. Okay, so, testing one time absolutely has clinical utility. I hope I didn't inform you otherwise. Testing one time is going to give you a picture of the week, the month, and the 3 months before the data service. That's wonderful. That's where you can begin to make actionable changes. So there is utility. And like any other test, there's always retesting scenarios, right? Whether it's hemoglobin A1C or lipids or thyroid, you're always going to want repeat measurements to really assess the efficacy of your interventions and, guide you towards the best outcomes. So yeah, so test one time is better than testing no times for sure.
Mm-hmm. The next question was, do you have a washout period prior to rechecking? from Patrick Feta.
Dr. Bruno?
As far as rechecking the micronutrients, is that what we're referring to? Yeah.
I think it was said during the
And
NutriPro.
washout time meaning time that we're not taking nutrients, not like not taking your supplements.
Patrick, if you want to clarify.
Okay. Well, what I would say is what I do clinically is it depends, because if I want to see how the patient is coming into me as their foundation, right? What they are already eating with the stress they're under, with the supplements that they're taking, I want to see that. And then when I'm checking their treatment plan, so 6 months later, I want to see where are our levels based on what I have prescribed. So that is normally what I would do as far as, how to test with nutrients. Now, there are also some providers who want to just see what is happening with just their physiology, and they're not looking at, they want them off all of their nutrients, and then that would be up to their own discretion.
All right. Let me see here. I see you mentioned fertility. I have a female 32-year-old trying to conceive. Do you have evidence-based positive results? Is this referring to NutriPro?
Ooh, I want to answer that one because it's
right.
It's a cool study name. There was a really cool study called the Mama and Bambino study, which might have been done in Italy now that I'm thinking about the Bambino, but there's definitely studies of, nutrigenetic testing during pregnancy to help identify kind of fetal outcomes, and looking at kind of paired dyads between maternal and, infant genetics. So there's lots of evidence in this area. So I say test and, schedule a consult, and we'll be happy to guide you through that.
All right. And then one other one here. Can you test pediatric clients? Is there anything we need to be aware of when testing the pediatric clients?
Mary Beth, do you have it? Will you answer that for the micronutrients? I mean, the genetics are going to be the same, where, as far as the NutriPro goes, and then Mary Beth, I'll let you answer about the micronutrients on that.
Okay. Yeah, I mean, we have plenty of practitioners that use micronutrient testing in pediatrics. Currently, our test was validated in an adult population, so the reference ranges that populate on the report are for adults. However, there's definitely established, especially for serum and red blood cell, there's well-established reference ranges for pediatrics from other laboratories, including like the Mayo Clinic pediatric laboratory catalog. So we absolutely routinely every day see micronutrient testing and NutriPro testing done in pediatrics. And we have 3 team specialists that have pediatric expertise that are happy to guide you through interpretation.
All right. Let's see here. There's a question here. I'm not sure how to word that one. Can you guys see it?
I'm sorry, in the chat?
In the Q&A, sorry.
Oh, Q&A, okay. Please indicate which labs, so you have the results. I'm not sure. I may not be seeing the question that you're seeing. I don't know if it was answered or dismissed.
Patrick's question. So you have your results on the day or retest, do they stop taking the nutrition?
Oh, so do you have your results on the day or retest, do they stop taking the nutrition? I think this question, it's a little hard. I'd love clarification. I think that may be similar to the question that came in about, do you do a washout period? We get these questions so frequently, and we try to say, do what the person's norm is, test when they're eating their typical diet, test when they're taking their typical supplements, test when they're doing their typical exercise regimen, test when they have their typical stress level. And then of course there's the alternative approach, which is test when they're at their worst stress, test when they're, undergoing, life events, eating a poor diet, there's no matter what, when you test, you will be guided in your, diagnosis and your interventions. So test.
All right, so I'm just going to give some closing remarks. Thank you to all your attendees for your engagement in your business. Vibrant America appreciates your support and the work that you're doing to advance the functional medicine, disease prevention, and wellness model. Immediately following this webinar, you'll receive a short 5-question survey. Please complete the survey so we may gain insight into how well we're meeting your needs or how we may improve the clinical lab education programs, products, and services we offer you. Thank you.
Thank you so much, everyone. Thanks for spending the evening with us.
Good night, all.
Good night.